Hello, good morning, everybody. Again, thank you for participating in the breakout session. I've already talked a lot, so I hope not to talk too much in this breakout session, but happy to answer any questions. I know there was a lot of information in the previous presentation, and maybe across different disciplines, so some of it not quite digestible the first time. I hope I was clear enough. But something that we thought about with Elizabeth and the organization of Breaking Barriers was that maybe what we could talk about in this breakout session was how the research can have an impact, at least in the school setting. And we worked very hard. UCSF is an institution that does translational science, and especially in the clinical world. So we want to take discovery rapidly to use in our patient populations and participants in research. That's why we have research and clinical activities in the same location. So we all know that basic theoretical science is very important, and there are some institutions that concentrate very much on that. UCSF concentrates more on research that is applicable. And in the same way, in neurodevelopmental differences and disorders, the way to really make our research applicable and significant for our populations is to work with schools, and work with schools directly with our discovery cohort. So we talked in our previous talk about how the UCSF cohort is a discovery cohort, is not a discovery cohort just at UCSF, is also a discovery cohort in the schools for kids with learning differences that we work with. And so I thought that it was a good idea today to invite some of our really partners in our studies from the Chartwell School in the Monterey area, and so that they can give their perspective on how the study has had impact in their schools, and how then they're thinking of ways in which what we've learned in our partnership can be scaled through technology and through their teacher institute to public schools and teaching in general. Of course, we also need to work with School of Educations and to train the new generation of teachers. Our first discovery cohort is really within schools with learning, was at the beginning with schools for kids with learning differences, so that we could have right away a large discovery cohort that we could work with from different perspectives. So I'd like to introduce the leadership of the Chartwell School. That will tell you a little bit about what the school is about and how the partnership has worked, and how they're also doing another step of translation to public schools. So I'll give the word to Kate Mulligan, who's the director of Chartwell, and maybe you can introduce the other members of the school. Thank you for coming.
Certainly. Yes, I'm Kate Mulligan. I'm the head of school at Chartwell, and with me is Jodi Amaditz, who is the director of the lower and middle schools at Chartwell, grades 2 through 8, and Billy Swift, who is the director of student support at Chartwell.
So Kate, do you want to maybe tell us a little bit of what, I'm not sure everybody knows Chartwell, so about who the school serves and what your approach is.
Sure. So Chartwell is a school for children grades 2 through 12. We're both an independent school as well as a non-public school, and we address issues around for children who think and learn differently. So about 80% of our lower school population is documented as dyslexic, and so we do a lot of literacy intervention at the lower school. And then as our children grow into middle school and we add new students at the middle school and high school level, the profile changes a little bit. And we address a wide variety of learning profiles, including executive functioning, ADHD, and Billy and Jodi can tell you a little bit more about that. They are also the directors of our teacher training program, and that's another reason they're here today, because as a small independent school and non-public school, we know that we can only reach a certain number of kids on our campus, but it's our goal and the goal and mission of our board of trustees to have outreach that goes well beyond the borders of Chartwell. So we like to share our expertise with our colleagues in the public schools surrounding us in the Monterey area, as well as the other private schools in the Monterey area. So Jodi, can you expand on the Chartwell student learning profile and how we do the work that we do?
And maybe Jodi, how the work with UCSF has impacted it a little bit.
Yes, so I think that I believe that everyone was at Marilu's presentation, and she talked a little bit about how our students are assessed by UCSF. And so then what happens after they go through that battery of assessments is that we have meetings with the families, key members in this process, and the UCSF team and our team of teachers. And so we all meet to discuss the findings of and the results of the assessments. So then what we do at that meeting with that entire team of parents, teachers, our mental health practitioners, the team at UCSF, is we determine, based on the student's specific learning profile and what they discover, how can we best how does that best inform our instruction in the classroom? So what can we do at Chartwell to modify our instruction to best serve the student? So we already know a lot about our students. The students who come to Chartwell all have neuropsychs or psychoeducational evaluations ahead of time where we learn a lot of information about them. We group our students in classes based on their learning profiles. So we know a lot, but we find out so much more from UCSF. And we find out more about executive functioning, attention, social emotional abilities in particular, in addition to reading and spelling and math abilities or levels. And so then what we do is we then rethink about our instruction, and we implement the instruction, and then we follow up through UCSF in the outcome study, but with Dr. Bob Hendren, and we fill out surveys and forms to see if the intervention is making a difference. So that's pretty much the gist of what we do with UCSF, but I think the really important work is educating our teachers more about the neuroscience. And then in our teacher training, we use that information not only by sharing with our teachers and parents and staff at Chartwell, but we want this information pushed out, right, as far as it will go. So in our teacher training, we share all of this information with the many teachers who come from school districts, and we have a whole section of our teacher training on the neuroscience of learning differences, in addition to in teaching curriculum and for the teachers to use in the classroom. So it's educating beyond Chartwell, which is really our mission, is for the most children to be affected by what we learn from Marilu and UCSF, and to help them share it in their classrooms. So I'm sure Billy has more to say. So I'm going to let him talk for a little as well, if he would like. And also, I mean, I would love to hear from all of you if you have more specific questions about how we do that, because that's that's the best way for me to share information, is to answer specific questions and not speak in generally. So I'll let Billy speak too, because he always does such a great job of touching on what I miss. And then and then if there are questions, we would love for you to post them in the chat, because I would love to share specific examples of how we do that at Chartwell, and then how we also push that out into the public community. Go ahead, Billy.
So Jodi and I both co-teach and co-direct the Teacher Training Institute that we do. It's strictly right now around structured literacy, but we do a lot of philosophy, and then we talk about direct instruction and takeaways that we want the teachers to have. And we're really trying to change how they're viewing, in the same way that Marilu was explaining in her presentation, the holistic view of the child and how important that is for their academic success. And when I say academic success, you know, we do social emotional learning at our school, but we also call it, we call it SEED, so SEAD, so it's the Social Emotional Academic Development Program, because we see that a student's success in school is directly related to their emotional, where they live emotionally and how they interact with the academic piece. And what I think is really important with the work that we do with UCSF is that, you know, we're a school that's been around for quite a long time, 35, 8, how many years now, Kate? Like 38 years maybe, in that range. You know, we've always been doing work, the methodologies and the approaches that we use are all research-based, but right now, working with UCF in the model that they test the students, we have real science with our students. It's not just a research base, like this is what's proven, this is what's proven for our specific students. You know, so we are able to individualize what we do, the approaches that we do. So almost every single student within the realms of our possibilities here on campus, we can cater each student's academic program based on their learning profile. So the feedback that we get and the observations that we make. And the other part that I think is really, really important is there's reasons for the behaviors. As teachers, we always think that we're doing formative assessment all day long. We're making observations. And so we want to look at where, like, why are we seeing the things that we're seeing, right? And so the work that Marilu and everyone else does at UCSF really pulls back what we see as sort of the overt observation. And she helps us and the rest of her team understand, like, where they're manifesting itself from, where are these students' strengths, where are their stretches, areas that we can build on with a strength-based approach. And just understanding that there's biology behind it, there's neurobiology behind it, there's internal feelings and emotions, there's external stimuli and factors that play into their well-being to be successful. Looping the family in on these conversations. I mean, it's an incredibly holistic approach that's backed by research for our students individually. It's been very impactful for us, and I think the families and our students' success.
Thank you. And I know that hearing this, and it's, you know, many of you might think, well, this is really not scalable. And this is a discussion that we wanted to have. I mean, most of the research that we do, even in the medical clinical sciences, is not directly scalable. What we do is that we do a deep dive with a small to medium population to do discovery, and then we create tools that can be tested in a larger environment. So I wanted just to make sure that we were giving that idea. This is our discovery cohort. It's such a unique cohort because it's across a school and a medical center, and hopefully, you know, and much of our research is also informed now by our collaboration with Berkeley and the School of Ed and technology partners, so that from the discoveries of this research that we're doing, we can create tools and algorithms that are much simpler, that they don't need to go through all these hours of testing and stuff, but that we can create pathways to more simple and effective interventions that have actually been proven effective in a large cohort. And yeah, and I saw Jodi, you were raising your hand, please.
Well, I just saw a question in the chat that said, how does the UCSF research impact your interventions? What effective interventions have you identified? I don't know if everyone can see this. And what public school districts or other child serving agencies are you working with? So I just wanted to start by saying that I taught Orton Gillingham. So I learned a specific Orton Gillingham program that I taught in a public school, middle school, for 20 years as a teacher in a public middle school in New York. And I did teach over 400 students diagnosed with dyslexia. And what was so fascinating to me over the course of that time was that not every child with dyslexia was the same, right? The way that the intervention worked or didn't work, right, was different for every kid. It was just very fascinating that some students learned to read much quicker or better, let's just say better, right? Quicker, better than some. And what was different? What I was doing was not different. The amount of time was not different. The instruction was not different. So what was different? And working with Marilu, I've now discovered, oh, there are phenotypes of dyslexia, of course, right? So the one type of intervention that I was providing was only catered to, one or two of these different cognitive processes. And it did not take into account, what they don't take into account is the emotional, right, component. And what I always said was I always said it as, this child is not able to access learning, or they're not available to learn because they were so emotionally shut down by what having a learning difference had done to them. Right. And I think that that's a huge piece of this, in addition to other things I had never thought about as a teacher, executive functioning, attention, right, in terms of reading specifically. And so now what we're learning from Marilu is that all of these play such an extreme role in a student who is suffering from a learning difference, and not just because of phonology or orthography, right? So orthography. So how has it changed what we do at Chartwell? It does change our intervention, our reading intervention. It changes a lot our math intervention. We're finding out students who are stronger with verbal reasoning versus visual spatial reasoning, for example. So we would teach math in a completely different way. We'll have some students verbalize their thinking, and then they hold on to the learning better and retain it, as opposed to students who really need a visual spatial model in order to learn conceptually. And then those students who with dyslexia, we know really struggle, most students, with the sequential processing and how difficult that is for them. So that we group students, we use different intervention strategies. We sometimes keep the same ones, but build on the areas that we know are a strength for that student. The public school districts that we work with, mostly we have, all districts in the area, but we have a partnership relationship with Hollister School District. We've trained their teachers in their elementary school in 5 elementary schools at this point, over approximately 200, I would say getting over 100 teachers in the elementary school. Teachers, not just the special education teachers. And so they're using these interventions in their general education classrooms, and also North Monterey, Santa Cruz, other districts in the area as well.
We actually have had representatives, teachers from over 27 different public school districts or private schools or charter schools attend our teacher training over the last 3 years.
There was another question. Is there any connection between dyslexia and physical coordination? It's a very interesting question. I think many of us have the experience that children with dyslexia might have difficulties with fine motor skills, or sometimes even with gross motor skills. It's interesting to think that, we talked about language being localized in the left hemisphere. And why is that? Why is language in the left hemisphere and visual and emotional processing in the right hemisphere? I mean, it's a big question that has never been answered for sure, but the thought is that language evolved in the left hemisphere because the first objects in the history of mankind and in the evolution were manipulated with the right hand. So for some reason, we started manipulating objects and using tools with the right hand. And when we started doing that to communicate effectively in our groups, we started giving names, sounds to these objects. And so basically language started developing and evolving in the areas in the brain that were close to the right hand. And the right hand is represented in the left hemisphere. And so that's how basically language took over the left hemisphere. But it's still linked to the system that we use to manipulate objects. So we actually think that in linguistics, words and verbs and words that denominate objects are very left hemisphere, while words that denote emotions might be more represented actually in the right hemisphere with words where emotions are. So in this context, there might be vicinity or even causality between some of these sensory motor processes that are necessary for fine motor movements and eye hand coordination. We know that some kids with dyslexia are very good at sports and some others are not, and some others, but in general, they're better at sports that don't involve balls. So martial arts or swimming, or maybe sports that whenever it's possible, there is an interaction with animals. So because they go to their strengths that are not these kind of maybe fine sensory motor issues. In some cases, I think that is the cause of the dyslexia. So the development of motor speech, we develop our phonology by pairing sounds to movement of the mouth. We've all experienced newborns kind of imitating, right, the movements. That's where language and even reading starts, because phonology starts there, associating the right movements of the mouth with the sounds in the auditory system. So if motor speech is impacted for some reason, then phonology will be impacted too. But what we actually need to treat is the motor speech part, not the phonology per se, because the cause is actually the motor speech. And this is an important thing and is an important aspect that, for instance, we could do quite easily, is to make sure that we check and we screen before, or at kindergarten, children that have had services for speech. I've talked with Elizabeth and with Kristen Wright about this in different occasions. Kids get speech and language services when they're very young if they have delayed speech, and then we don't follow them through school. That would be a great way, a great population at risk to start screening in kindergarten for reading. But there was been a disconnect between the speech world and the reading academic world, and that it would be very important if we could, as I know Breaking Barriers is talking about and working on, integrating data from different services. This would be one that is a very low-hanging fruit for academic skills. Sorry, I'm talking a lot. Billy, did you want to say something?
Yeah, I wanted to tie in just a tiny bit with that too, just from like the educator point of view and Chartwell School. We have, the students that are here, either privately sent or sent by a district, or students that are here on financial aid, or however they get to us, right? About 40%, maybe even 50%, I would say, receive some sort of speech and language or occupational therapy service. And a lot of them, they overlap, so they get multiple, right? When you think of like a dual diagnosis or comorbidity, a lot of our students come to us with like a SLI, so a speech and language impairment or something like that, where they're having difficulty with the integration, the articulation, those fine motor skills, the fine motor skills in the hands, or the gross motor skills. As an educator and looking at how to support our students in the classroom, with the feedback that we receive, especially through UCSF and then the specialists at our school, they need maybe certain ways, certain tools for sitting to help them to be able to write correctly, to get their eyes positioned in the right place, that they're looking at certain pencil grips that they might be using. There's therabands they use for attention and control, you know, especially like trunk strength, just to make sure that they're sitting upright, or their slant boards. So there's pieces that we can put in to help the students to help with the marriage between the physical coordination and the task that we're asking them do. Just a moment ago, I was watching some of our students. I don't know if you could see it, Jodi, outside of our window, but students doing games outside on whiteboards, decoding words, running and rolling and doing all these other things. So you think about what Marilu was even mentioning with executive functioning and ADHD and attention, that movement in education is incredibly important for them to engage in the content, keep them active, and help them make associations. So it goes more like, it builds those pathways better, especially for certain types of learners.
And to Elizabeth's question, sort of building on what Marilu said. So, and maybe you want Marilu to answer this, but yes, the family is a really intimate part of, we share the learning profile with the family and with the school. And then, as Billy explained, the other providers who work directly with the children are part of our team here at Chartwell. So all of us are in this together, and everybody gets the same information and also has an opportunity to provide feedback. So that's, you know, I hope that answers that question, at least in our case, that is how it's done. And Billy's team, student support team, includes our, you know, SLP, as well as our occupational therapist, as well as 2 counselors, as well as a team of people who work one-on-one directly with our students. And he coordinates that group, and they're a regular part of our faculty meetings. They're members of our faculty.
In particular, for our collaboration, yes, the family is part, and we do share what we learn. Some of what we share is more of the standard evaluation, but we also, again, in the spirit of UCSF being a service-oriented institution, we provide our clinical expertise to the families as well. And the way that we're thinking of scaling, again, this kind of discovery collaboration that we have with Chartwell and Armstrong and other schools for kids with learning differences, is to create state centers that hopefully can serve kids in public schools. So have partnerships between specialized schools like Chartwell, School of Educations, where we can train each other, you know, teachers can help the medical professions understanding what kind of treatments really they're using with children. I mean, treatment in a good way, in the sense that if you think of treatment, even in the physiotherapy way, we're building these brain networks for the kids, and the ones who are building the brain networks are the teachers who are with them and teaching them to the different brain networks every day for hours. So the idea is that we will have these centers of excellence in which we can have a community of providers from education, medical, speech and language, psychology, all working together as a one-stop shop to be of service of families that are and teachers who are in the public health systems, and teachers and educators from school like Chartwell will be part of those center of excellence. So we can think we have a great, you know, our great UC system, but also great other institutions in California like Stanford. So we could think that there could be a hub around Northern California or Central Valley or Southern California, and various different, we have this, and the idea was modeled by the Alzheimer's disease research and clinical centers. So we have these centers for Alzheimer's disease where I work, where I wear my adult cognitive disorders hat, and there we have all different providers that work together. We do education to primary care physicians. We need a model like that in which we start from the discovery cohorts and then work to build out our program. Also using technology. So there was another question regarding how young the children are. And now we have started on the big phenotyping study and collaborations with the schools. We've started with 2nd grade, but now that we're building an app to screen pre-readers in kindergarten and 1st grade, so we'll start with younger children as well. It will look differently, but yes, Jodi?
Yeah, I wanted to piggyback on what you were saying, Marilu, because I read the question in the chat, and I think you did too, about what was the youngest age group you've worked with, and so you answered that. Yes, Marilu, and
oh,
so
sorry.
You even see that because you just answered that question. you said what was the earliest that you just
No,
said?
I did. Sorry, I just.
Yeah, so I just wanted to also.
For it. I saw it and I went for it. That is my impulsivity.
So I was just going to say that when I was a teacher in the public system back in New York, 20 years ago was screening students in kindergarten at the end of kindergarten to see if we thought that in 1st grade they would need reading intervention. And the way that we did that was by using some of these screeners of phonological awareness and rapid naming assessments and just sight word reading and things like that. And so we were able to determine who we would put into groups for remediation in 1st grade, starting in 1st grade. And then when I moved to California, I noticed that a lot of the students at Chartwell don't come until 2nd grade because those practices are not common in most schools, is what I have experienced personally, that those practices are not in public schools now. So in our work with Hollister, we've been bringing awareness to these cognitive processes to the teachers so that they have the tools to assess their students so that they can start intervening earlier. And they have been, and in Hollister in the last year or so, and the feedback that we've received so far from the teachers that we're still in communication with and the principals is that it's really already making a difference, that they see a difference in their early readers in their early elementary schools. So I think that this is the goal of all of this work is to begin to educate the educators so that they can teach the students in the classroom and see a difference throughout. And that's, so I've worked with students with reading. I think the question was for Marilu, but I also wanted to bring it back to the classroom. And I think that all of this can be brought into the classroom starting, as early as kindergarten and maybe even earlier, right? To understand the students' learning profiles of the students in your class and start to teach to the way that they learn best.
Right. No, thank you, Jodi. Yes,
one of the,
really, always bring it back to the classroom. I love that. I love these conversations, and we can go at all different levels. And go ahead.
One of the things that we do during the TTI is we do like a pre and post sort of like test just to like check on knowledge. And so just tying into what Jodi's saying, so we want everyone that does TTI with us, the Teacher Training Institute, we want them to leave with having feeling really confident in what they're doing. And a lot of teachers are coming into us to do the training, and they don't understand, they don't know what a phoneme is. They can't isolate how many phonemes are in, like a 3-letter word or 4-letter, they have a very hard time with it. So we're doing a lot, and they leave and are this is what I need. And they feel so confident and they're bringing it back. And then with that confidence, it starts a whole spiral. That's the amazing thing about confidence, right? It's like one person dancing, another person joins in. Next thing you know, there's a big party. And it's really fun to watch everyone at Hollister get really excited about what they're learning and how well their students are doing.
So there was another
Great,
question.
I see, yeah.
And I'll let you speak, Marilu, but I just wanted to say, I know there are a lot of mental health people in the audience, and I wanted to say that, what Billy and I have also experienced working in education for a long, long time is the emotional difficulty of students who struggle with learning differences and how that impacts their lives over time. And so the earlier that we can learn about how they learn and help them in the classroom, right, the less likely they are to have a negative school experience and then negative self-experience. So I just wanted to add that in. Also, someone asked for us to talk broader than dyslexia. So Marilu, did you want to touch on that?
So a couple of things, a couple of very good questions. I'll just take it one at a time. You know, the idea of growth mindset and the fact that, you know, if we have these differences to start with, then how do we apply a growth mindset, which I really love. And I like that the concept, you know, we can all learn. We might need to learn differently. You know, we don't all learn in the same way. So I don't think the two concepts are in conflict with each other. They're not at all. Actually, we need each. You know, it's the idea also of precision medicine, isn't it? We just there's precision thinking, so we all think in different ways, and we can all learn. But we want to make sure that, especially in these extreme phenotypes of different way of learning, so we give people the tool to be able to learn. And thank you for the other question, who's is very dear and important to us, especially in our collaboration with other members of the psychiatry department, as that we started in the last couple of years with the director of the San Francisco General Hospital. Will, as you know, has a lot of population of individuals in traumatic and adverse event situations. And how does that affect the brain, and how does it interact with school outcomes? This is another world in which the fields have been too separate. You know, there has been a lot of work of the mental health consequences of trauma and traumatic situations for children. But as we see how the brain is all interacting, those have an educational impact as well, and cognitive impacts that have not been studied enough. We just wrote a grant with the director of psychiatry at San Francisco General and our director of outreach, Michelle Porsche, to analyze a cohort of adolescents that have been studied in a multidisciplinary study all over the country. Imaging, cognitive testing, a lot of social determinant of health information, and we're gonna try to put them all together and do an analysis to see really what are the brain impacts of trauma apart from executive functioning and addiction difficulties that have been well proven, especially addiction. So it's not enough to say that trauma causes negative life outcomes. We need to know more. We need to know more. How does it affect language networks or emotion networks or executive functioning networks or visual spatial networks? And how does that then impact how we teach and care for children who have been in traumatic situations? So again, the trauma is, the brain is built a certain way, and then it's plastic and it changes, especially in the early years, depending on what environments it encounters. So it's, you know, it encounters trauma, those networks that regulate emotions and understand emotions are going to change. And we need to use that knowledge on the plasticity of the different networks that respond to trauma to inform not only how we care for them in a mental health behavioral perspective, but also how we care for them educationally. The two things need to go together. They cannot be separate and can inform each other. We don't really know how the brain of a child who doesn't read because he's never gone to school because he's been in a very violent environment looks compared to the brain of a child that has dyslexia, compared with the brain of a child that doesn't have dyslexia but is not being taught how to read, but is in a supportive family and societal environment. These are all studies that we need to do together, I think, and I'll let others comment.
I had to step away for a minute, but I wanted to, we were talking about sort of the emotional component that's involved in this, right? The mental health aspect as well, is that correct?
Well, we're talking about how this work can impact how we can study, learn, and care for children who are in traumatic situation, not necessarily because they have a, because they have a learning difference, but because they are in traumatic or environments. And actually, the study we're doing is really looking at the difference between trauma and discrimination. So the acute violent trauma, they're called category A. So really violent environment, having experienced death or having experienced abuse during their lifetime for children, or the chronic stress of feeling racially discriminated. Those two, what are the behavioral and cognitive consequences on those two? They're probably very different.
So one of the pieces that I think is important, like Jodi was just talking a minute ago, sort of about like the Matthew effect, and about how, as you get a little bit older, there's a bigger gap in academic like achievement sometimes if the right interventions aren't put into place and we don't identify something early. And when Kate earlier was explaining our school, it's sort of like how our profile of students that we see, we do a lot of remediation when it comes around, literacy and reading early on. And then we get more of like an ADHD sort of component built in for middle school. And in the high school, we do have a lot more like emotional depression, anxiety, pieces like that. And I do believe that that trajectory, and this is again my own belief, I don't have any research to back this up, but we see a lot of that. Students that have negative school experiences, they start to feel pretty bad about themselves, they become anxious. And so as they get older, just in the same way that we see the Matthew effect kind of start showing gaps academically, we start to see gaps emotionally and people being able to feel good about themselves and how it impacts the relationship with themselves and others. And what I always like to think about too, when we talk to families and other teachers and we do the trainings, the idea that when the students arrive at our front door, we start school at 8:30, but if they show up at 8 o'clock, a lot of them have already had they could have had a pretty serious moment. We don't know, we see them, they get out of the car, but we don't know necessarily the reality of what they're experiencing or how they're interpreting their reality too, about like, are both parents at home? Are they getting good food? Are they getting in an argument? Is something happening? Are they stressed about something, right? They leave us and they have this whole other part of their day, these other 16 hours basically that they're living and going through, and we only see them during a certain part. And so there's a lot that they will bring to the campus with them. And a lot of especially our students are students that, we all have our areas of confidence. We all have our areas of hesitancy where we don't feel very good. When we are pushed to do something that we're not confident in, it can be stress inducing and create a lot of anxiety. And for a lot of the students that come to Chartwell, school has been traumatic for them. They do something every day that scares you. Well, going to school every day scares them, and when you live in that world, and to be able to find people, right? The teachers and family members and other people that start to really understand who you are, and you feel good about who you are, and you get the interventions that you need, and you realize I might, be learning, I might think a little bit differently than other people, and this other educational environment isn't working for me. I need a different approach, right? And they really can stop struggling and start learning. It's kind of our motto at our school. And we see what we call the Chartwell effect. After a couple of weeks, the kids are excited to come to school. The psychosomatic symptoms of the belly, or they're actually not psychosomatic, they're real symptoms. They have the belly aches, they have the headaches, they're angry, we're seeing, maybe like oppositional defiance stuff. A lot of this stuff kind of can start shedding away. And I think I think part of, looking at the phenotypes, and the work that we do with UCSF, having those conversations like we do every Wednesday at our school, we have student talk. And so to be able to go and discuss like, oh, is this happening in your classroom? We'll talk to the specialists at, here at our school. And then, oh, maybe we have to call home. Let's pull up the UCSF report, and we do that. I don't know if we talked to you about that, Marilu, but we do. We pull up our notes a lot to think about the whole child and how we can provide the best scenario for them, because in order for them to really be successful, not just in academics, but with their interpersonal interactions, family, they need to feel good about themselves, right? We need to reduce the stress and reduce the anxiety.
Yeah, we can imagine how, you know, without that support, you know, you can imagine a child with this type of difficulties in a traumatic environment, what an explosive combination that can be, what kind of trauma that can be. So thinking about the more, you know, trauma end of the situation that I understand all of you are very familiar and invested in, and thank you for all the work that you do. And I can't even imagine the situation in which we are now. So definitely I wanted to express my personal thank you. My high schooler is in public school, and I've seen all the difficulties in the city, and so really appreciate all the work that you do. So how does the understanding of blame plasticity mitigating trauma engage the student's family? Yes, I mean, we know that these are such, I've been reluctant to tell you the truth oops, I'm sorry about that, to engage in the world of trauma. You know, I'm a behavioral neurologist. That's not my specialty. And it took me a while to understand how relevant I think the work that we do in behavioral neurology, and not just in psychiatry, is relevant to trauma, because trauma changes the brain. And in the way it changes the brain, then the behavioral neurologists and neuroscientists are the most knowledgeable people to look at changes in the brain. We weren't able to see those changes in the brain before, but now we are with the tools that we have. And that's how things switch between psychiatry and neurology. And how do we engage families? I mean, I don't have the answer to that. I think I can give you a general answer that I think education and knowledge is always helpful to anybody in any situation. And there's a lot of blame going around between the different worlds that care for children. And I find that even in the, let's say, easier world of learning differences compared to trauma, underserved population, discrimination, there are incredible things that can happen even in families, in parents, once you take away the blame and try to really understand, you know, where things are coming from biologically. So in the work that we're starting to do with the Mission Dolores School in San Francisco, which is a school for kids from underserved situations, we will really have a concerted action to try to understand how to educate parents and to science and the kind of in a neuroscience of the brain in a way that it can be digestible. And we're doing this at the Memory and Aging Center, also related to aging and changes in neurodegenerative disorders. So I'm hoping to bring to the study also the adult world, and there are educators that are expert in educating and informing populations that come from underserved and maybe less educated environments than us in this panel today, and how to get the message through that we can help by trying to preserve brain health in many different ways. So it's an kind of a general answer. I don't have a specific way. We're just starting to do this, but I do think that if we have the mindset that we all can learn from each other, if we put all our minds together, we can try to help in whatever situation. And that knowing some basic data points about the brain and how the brain works and who's, you know, how we trying to help is very important. Does that make any sense? Does anybody want to rephrase what I said better? I guess the main point is, you know, having some education about brain functioning I think, will be a way, I hope, to interact with families in any situations. I think it's worked in this kind of privileged discovery cohort that we're working with. I think we can modify the approach to work in different situations. So Elizabeth is asking, if the children are involved with other child-serving agencies such as child welfare, do you coordinate with them as well? I'm not sure if the question is for me or for Chartwell. I'll let maybe Chartwell answer first, and then, do you have children that do you work with other agencies? I do remember one child that we worked together with who had epilepsy also, that we coordinated, try to help with other agencies, but it's not typical. And I would say that is not typical for me either in the research setting. When we will get to a clinic, we don't have a clinic yet at UCSF specific for learning disabilities, but we will soon. So I don't think we are the best group to answer that question, I'm afraid. We, of course, talk to other clinicians and teams that are involved in the care of children outside. We always open talking to other health or educational specialists or speech therapists or any other professional that is involved with the children. I'm sure Chartwell does that too. Again, trying to bring everybody on the same page on how to approach the child. I find myself sometimes, we've had this experience too, Jodi. One of the, talking about the neurobiology of the differences, we had a child at Chartwell who we, discovered looking at MRI that they've had a little stroke that actually, it was known to have caused some mild difficulties with hand movement, but no one had really put together that that little stroke was causing his dyslexia. And in that case, was one of the cases that was so apparent how there was no coordination, because the child had services his whole life up until like the age of 10 when we first saw him for the movement, for the mild difficulty of his hand movement. He was followed yearly and given physiotherapy, but his dyslexia was never even considered as part of that. He actually had never been given an MRI. It was just such a, I could not believe how much we could have done. And he's doing great, and Chartwell has done great for him. And I'm not saying, but a lot of the cost and the care and the that he could have been followed back from that day, and probably we could have prevented his dyslexia and difficulties in the academic world. So I'm sure there's so many of these children that if we worked all together, we could catch and coordinate care much better. Is it ever a concern that this information on specific children's makeup would ever be used to label students? In my work, it is so subtle when school folks unintentionally label students. That's always a problem if we label for good. It's part of the whole process, I think, of destigmatizing brain diversity or mental health or behavioral health or however we want to call it. Sometimes we need to label to give services. That's the whole DSM-5. The DSM-5 does not tell us anything about the neurobiological basis of psychiatric disorders. It gives names because so people can have medical care and insurance care, and not nearly enough. And so I think the IDA and all the labels are used to protect children and provide services that are needed. Of course, there is the other side of the coin of stigmatization that I hope we can work against. It is a risk. I don't know if you guys have a different perspective.
I think you hit it when you talked about removing stigma. I mean, you know, that it's not about this way this brain works is better than that one, right? Or it's about how does your brain work? How can we make sure that we teach you the way that your brain works so that you can be, you know, the best you can be, so that you can access your education and share something with us and be, you know, be the human being that will think differently and help the rest of us see the world differently. I mean, you know, we try not to, I think a label implies judgment, and a diagnosis is not a judgment.
Thank you all. I think I'm seeing 1 minute left. This is always so wonderful to come together and talk about these things from different perspectives. And I hope that as we continue in our movement, we can break even more barriers with all together. So thank you.
Team, on behalf of Breaking Barriers, thank you very, very much. We're really appreciative of your wisdom and expertise. Clearly, the value of this is self-evident if you look at the comments and the inquiry that your conversation has generated today. So thank you all very much.